Welcome back. Now in this revision, I will revise the passive movement. First, I will revise the introduction, the techniques and the protocols, and the different types of passive movements. And in each type, I will discuss the effects and uses. The passive movement, as I told you in the previous lecture, these are movements which are performed by some external force in an unrestricted range of motion. So when a muscle is not able to produce that contraction, and when we ask the patient to relax the body parts, that external force can be the therapist, the patient, the gravity, or different kinds of machines. Passive movements can be indicated in case of muscular weakness. Muscular weakness due to any kind of muscular injury, inflammation, neuromuscular deficiency, comatose is a bedridden patient. But whenever we go for the assessment and examination patient, we have to use different kinds of physiotherapist tools. The physiotherapist tools like the different types of techniques. So for that techniques, we have to perform many things in the passive range of motion to check the end field, the stability of the muscle strength, as in the manual muscle testing, and the limitation of motion. And whenever you are teaching any exercise plan to the patient, you have to teach that exercise plan. If the patient is not understanding with the commands, you have to teach it with the passive movement. Before the preparation of any kind of technique, you have to prepare the patient with the help of the passive movement. The techniques and the protocols are same as I told you in the resisted, assisted, and the free exercises. Starting position must be comfortable for patient and the therapist both. It says the proximal joint or the insertion origin of the muscle. The body part of the patient must be fully supported in a comfortable grip by the therapist. Traction, after every traction, there will be a strong contraction. The range must be completed in all activities. Speed and duration must be dictated as per the requirement and the pathology of the patient. Now the passive movements classification. It is mainly divided into two types, the relaxed passive movement and the passive manual mobilization. Relaxed passive movement is further divided into physiological movement and the accessory movement. And the passive one is divided into three parts, mobilization of joints, manipulation of joint, and the controlled sustained stretching. Physiological movements are the movements of the bony levers, all the flexion, extension, adduction, abduction, internal rotation, external rotation, supination of hand, pronation of hand, inversion and eversion. All these movements are the movements of the bony lever. So these are the physiological movements. For a physiological movement, a therapist must be aware of the anatomy of the structure, anatomy of the joint, and feel the range and the pattern of movement. Otherwise, he will not able to perform it in correct manner. The next one is the accessory movement. These are the movement of the joint surfaces. When our joint surfaces are moving, that is the accessory. Accessory movements are the part of physiological movement. Whenever a person performs physiological movement, there will be accessory movement. But patient cannot perform these accessory movements isolatedly, cannot perform by itself. But as a therapist, we can perform it. So all the types of sliding, gliding, rolling, and spinning at the joint surfaces. At these joint surfaces, these are the accessory movements. You can see the one is the rolling and the second one is the sliding. The lifting, whenever a person lifts the hand, this is the physiological movement. But the movement which occurs at this joint level, that is the accessory. The effects and uses these movements whenever we perform the passive movements. It will help to prevent the formation of adhesions. Adhesions, synovial joints are prone for the adhesion formation. So always perform passive ROM to prevent the adhesion formation in the specific synovial joint. It always preserves the memory of pattern until the response is generated, maintain the range available, and it will improve the blood circulation. As the muscle is not contracting, there will be the pooling of the blood. So whenever a therapist or a patient is performing by himself, by some external force, it will add the pressure in the add the pressure at the muscle. So it will improve the blood circulation. It will improve the venous drainage and the lymphatic drainage, and at that level, new blood will come. So it will improve the blood circulation. By all these means, the muscle will be relaxed at the end of exercise. So this or the effects and uses. The next type is the passive manual mobilization. It is divided into three: mobilization of joint. These are small, repetitive, rhythmical, localized movements. So then these must be performed at the joint level. Patient can control it. These are graded into different types. It will, in case of pain, spasm or productive spasm, these techniques are very helpful. In case of hypermobile joint, the mobility can be gained with the help of mobilization. And if the patient is not, if a patient is not performing any activity, like in case of fracture, in case of POP, you can do these mobilization to prevent the degenerative changes. The next one is the manipulation of joint. Manipulation can be done by two ways, by the physiotherapist or by the surgeon. If the therapist is performing, these movements must be accurate, localized, single, and quick. Single deceptive movement. Patients will not be able to stop it. So these are single quick movement, small amplitude, and high velocity thrust, manipulation or the thrust technique. But if joint is so much immobilized that the manipulation by the therapist is not helping, then it can be done with the help by the surgery. So in this case, anesthesia is required. The main purpose of giving the general anesthesia is to gain better range, to apply greater force, because if the patient is conscious, we will not allow to apply the greater force. But there are limitations of the general anesthesia. If there are multiple adherents, always stop breaking the adherents at the same time, because if it will lead to the further swelling and the adherent formation. The manipulation can be used for the repositioning of the sublux joint in case of dislocation of the shoulder, dislocation of the elbow. The manipulation can be used by the therapist to relocate the joint. The next one is controlled sustained stretching. So when an external force is applied to contracted structure for a period of time within the functional pattern of movement, so these muscles will become lengthened by inhibition of tendon protective reflex. So it can be used in case of the hemiplegic patient, in case of the spastic patient, when the muscles are very tight, when the muscles are in this contracture. So in this technique, the muscles are put into some kinds of coupling, and there will be a continuous stretch on the muscle, so it will lead to the lengthening of the muscle. In this diagram, you can see the turnbuckle plaster for the elbow. So there is the contracture of the elbow. This supplement will help to lengthen the shortened elbow muscle. The second one is CPE shoes, especially used for the talipes equinovarus. This is a congenital clubfoot of the neonate. These shoes are applied for a longer period of time. So in this way, the deformity, as you can see, in the clubfoot deformity will resolve with the passage of time. So it was all about the passive movement. After the passive movement, we covered we go through the walking aids. Now I start the walking aids. Walking aids. In this, I told you different types of walking aids, then how you can prepare the patient, and different walking techniques. So walking aids are devices which are designed for those patients which are not able to move in their life independently. So these walking aids help them to move. In the crutches, there are three types: the auxiliary crutch, elbow crutch, and the gutter crutch. In the sticks, unipod stick, tripod stick, and the quadrupod stick. And in the frames, I told you about the three types of frame. The first one is the static frame, rollator frame, and the reciprocal frame. The crutches, the elbow crutches are the simple, the wooden or the steel one. The steels are recommended because of the lightweight and the adjustability. It has three parts you can see in this diagram. The first one, the topper one, is the auxiliary pad. Then there is a hand piece for the grip, and the rubber ferrule. It adds the friction to prevent the slipping, and the central stud, it will make this steel auxiliary crutch adjustable. So there are different methods for the measurement of the correct height of the whole crutch and for the hand piece. It can be measured with the shoe on and the shoe off method. If the shoe off method for the auxiliary crutch, if The patient must be in the lying position, start from the axilla and end at the medial malleolus. With the shoe on method, start from the 5 centimeter below of the axilla and end at the 20 centimeter to the lateral to the heel of the shoe. And for the hand measurement, because of course the hand arm length is not same for all the patients. You have to measure it for all the patients. For this measurement, the elbow must be in 15 degree of flexion, because whenever a patient hold the grip, hold the axillary crutch, the elbow will be in the 15 degree of flexion. So measure it in the flexed position. Start from the 5 centimeter of the axilla and end at the ulnar styloid. This is the ulnar styloid process of the hand. So one rule which you must remember, always keep that axillary pad 5 centimeter below to the axilla, because if a patient is putting weight on the axilla through the axillary pad, it will lead to the neuropraxia of the radial nerve or the brachial plexus. It will add the pressure of these nerves. So always advise the patient, do not put the weight on the axilla through the axillary pad. The next one is elbow crutches. It is for those patients which have very good balance and strong arm and they require little assistance. So it consists of the 3 parts: the metal curve, the hand grip, and the rubber ferrule for the friction. The length of this heel one is also adjustable with the help of the central strut. You can see the different parts in these diagrams. The measurement can be taken from the ulnar styloid process to the lateral to the heel of the shoe, 20 centimeter. Elbow must be in the 15 degree of the flexion. The next one is the gutter crutch. It is for specific those patients who are not able to hold the elbow crutch. There are some kind of deformities of the hand, especially in case of the rheumatoid arthritis. Advise these kinds of crutches. It consists of 3 parts: the padded forearm, support, the handpiece, and the lens. So in this grip, strong grip is not required. The patient will stabilize the whole forearm on the padded forearm. So it will provide better support and also provide assistance. It can be measured with the 90 degree of elbow flexion in the standing position. So measurement of this one is the different in the standing, from the 90 degree elbow flexion from the olecranon process and then to the floor. In the standing position, 20 centimeter lateral to the heel of the shoe. With the shown method, the same one, elbow inflection, 20 centimeter lateral, but with the shoes. So in these videos, I show you different kinds of methods and techniques measurement. It was assigned for you for the measurement. The preparation for crutch walking. Always strengthen the shoulder extensors and abductors, elbow extensors, and whole hand flexors, hand extensors, and the hand grippers. Always strengthen before advising or giving any kind of walking aid to the patient. Strengthen the shoulder extensors, adductors, elbow extensors, triceps, and hand flexor extensors on all the muscles. In case of the leg, if the patient is going for the non-weight bearing, so in the non-weight bearing case, in case of unaffected leg, go for the adductors and the extensor strengthening of the hip, extensor strengthening of the knee, and the plantar flexor of foot. If there is a partial weight bearing, then strengthen both muscles, both legs. Non-weight bearing and the partial weight bearing, the patient have to put weight on single leg. You have to strengthen that single leg properly. But if the patient is putting weight half on the leg and half on the other leg and some weight on the crutch, you have to strengthen both legs. The balance, the patient. The crutch walking, in the crutch walking, I told you different types of techniques, non-weight bearing and the partial weight bearing. The non-weight bearing was a triangular gait. It was especially if the patient is not able to put a weight in case of the amputation, in case of the polio. It starts with a triangular base. The triangular base is formed of 2 crutches and the foot. This is the triangular base. So in this way, patient will shift the weight with the help of the auxiliary crutches. This is also the non-weight bearing gait, the different stances. In the partial weight bearing, I told you 2 methods. In the method A, it was a 4-point gait. you can see the patient 3 points. A patient will move 3 points together and then move with the other point. So this is the partial weight bearing with method A, and this was the partial weight bearing method B. It is also a 4 point gait. And it is also known as the reciprocal gait. The patient will move the right crutch with the left leg and the left crutch with the right leg. So reciprocal gait. The partial weight bearing can be done with the two methods. And the next, the different types of sticks. Mostly the wooden or steel both are available in the market. The steels are a recommended one because of the length and the adjustability. There is a modification in sticks. In the steel stick, there is the modification at the base. There is a tripod and the quadrupod stick. You can see the tripod and the quadrupod. It adds extra support and reduce the chances of fall. So it can be the exact length of the stick can be measured with the elbow in slightly flexed, start from the ulnar sclerosis and ends at the 15 centimeter lateral to the heel of the shoe. So in this way, you can see the patient will learn to walk with the help of the stick. It can be used with for different patients. It will depend. You can use single stick or the double stick. But if you are recommending two sticks, it's better to recommend a frame or some other device. Now the frame. You can see the frames. Frames are most commonly used walking aids. There are different types of frames. You have to taught the patient. You have to take the patient. There are different types of frames. The first one is the static one. There is the same fixed frame formation, but there is also a relative frame and a reciprocal frame. In case a patient is not able to lift a frame because of some uncoordinated movement, because of some ataxia, because of some kind of disease, otherwise related frame. There are small wheels at the ends, at the low base of the related frame. So these frames help to move for those patients. The reciprocal frame, these frames are movable. These are not the fixed one. It can be moved in the right and the left directions. It can be also used for the patients who are not good in the coordination. So these are the rollator frames you can see, and this is a rollator frame with the basket. So in this basket, patient can keep his important things with him while moving. Safety is very important. Physiotherapists must check the safety of all the walking aids, not only when giving to the patient, but also regularly throughout the treatment program. Always check the rubber ferrules. They must be with the high coefficient friction because if the ferrules are not good, there are chances of patient slipping and the fall. Always advise the patient how he can manage his walking aids, how he can buy different parts of walking aids from the market. So it was all about the kinesiology, preterm content,